Okay, we are right at 2 minutes after the hour, so we're going to get started. I'm going to have my colleague Christy Musser on the line as well. We've got quite a few folks in the in our waiting room and in our attendee list, so we will get started. As you probably already know, we are recording this webinar, so it will be available on our Knowledge Tsunami in the future. We always try to record all of our webinars, so you should see all of them out on our website. So if you're looking for one and you don't find it, let us know and we will do our best to get that to you or get the link to the webinar itself. Okay, I'm going to record as well. Okay, great. So today we're going to talk about some of the telehealth benefits now and in the future. Our goal is to look at the coding around telehealth, which is why Christy is here, our expert in coding and compliance. And this is my bio, but what's more important is the bio of Christy, who has been an agent of change and a dot connector spearheading quality and process improvement across multiple healthcare settings. We are grateful to have her. She has a tremendous amount of experience. I encourage you to connect with her and to reach out to her if you have any questions post the webinar as well, and me if you need to as well. So great resource to have on our webinar today. So we try to make these webinars as quick as we possibly can. So it's really at that 30-minute time frame to give you as much information in a small period of time. This isn't our lightning webinar, which are somewhere around 10 to 15 minutes, but we are in a shortened panel or a shortened webinar time frame. So around 30 minutes. We will be covering a lot of information, but please put questions in the chat. We will open those up. Certainly, if we see some that are pertinent to what we're talking about at the moment, we'll answer those on the fly. And if not, we will catch them at the end. But again, the idea is that we answer your questions through these webinars. So please feel free to put your questions that you particularly have in the chat. And if it's something that we can't answer while we're on the webinar, we'll take it away and get to you individually. So you can see the objectives that we're going to talk about today, and we'll be covering a lot in a short period of time. So let's talk about the rural telehealth past, present, and future. So as I said, we're going to talk a little bit about rural and then generally as across the country, all types of organizations. But rural has had a lot of changes in the last 12 months, really. So prior to 2020 in the rural area, we've had a lot of extreme limitations for rural organizations. And there's a whole bunch of socioeconomic barriers for getting technology that is anything from a device to broadband. And we don't have to communicate to everybody the challenges around that, but we know that there's some initiatives around legislation to help with broadband and devices. And we'll talk about that at the end, some services and some federal programs that you may be able to take advantage of. Since we've had since March of 2020 and through the end of the PHE, whenever that is going to be, the majority of those limitations have been temporarily lifted, obviously, which means that we have had more and more people utilizing telehealth, which means that we now are aware of all the limitations. So that's anything from kids who weren't able to go to school because of virtual school, and also healthcare, where folks were not able to access their healthcare provider because of the device challenges and the broadband challenges that I mentioned earlier. And then finally, what will happen after the PHE? We're not really sure. We don't know exactly what that's going to look like, but we have some ideas, and we'll share our thoughts on that in the next few slides. Christy, what would you add to this?
I would just say that, beyond the PHE, one thing we do know is that telehealth is not going away. It is here to stay. It's just, what is that going to look like over the next couple of years? There's going to be an evolution.
Yep, good point. And I think one of the topics that we'll do again is the virtual first discussion that we've had in the past. We had a lively webinar a couple of months ago on virtual first, which I would encourage you to take a look at. That we are seeing more and more payers putting restrictions on in-person visits and incentivizing patients to utilize virtual health first and then going to a brick and mortar location. So stay tuned, more on that. So the timeline for the federal waivers, we just had an extension in October. So we do have an end to the federal PHE somewhere around the 11th or 13th. And we're, those dates are a little bit smushy, but somewhere around there. Based on that, the waivers will extend for an additional 151 days. So somewhere around June of 2023, the waivers will end. Once we have an end to the PHE, which if it ends the next time, that next 30-day period, we will see it end in April of 2023, right? March,
Yep. So
January, February, March of April, March of 2023.
So if it gets extended, then it would 4/11 would be the next review. If it's not extended, then we're looking at the 151 days.
Yep, great.
Yep.
Or yes, thank you. Those are timelines that are just so crazy. And I know it's really hard for folks to understand. And people often have asked, why the 151 days? Why did they select that? And that question was asked in a forum that I was in recently. And they said initially when they did it, they thought they were going to be able to get the PHE extended for another year and wouldn't have any problems. But they did have problems getting a consensus and getting the votes for it. So at the time, this 151 days met to the, was connected to the federal Medicaid timeline. That's not the case anymore, but we still have the 151 days. And we know that some codes go through the end of 2023, which we can talk about those as well, but some are already defined to go through the end of 2023. We know if the end of the federal PHE starts in July at that point, then, or June or July, we know that we're then going to have another 151 days, which will be just about to the end of the calendar year, or we'll see things go through the end of the calendar year. And this is because of the ambiguous law that we've seen happen that says, any year that the PHE ends, that the waivers will go through the end of that year. It doesn't necessarily mean everything, and it's always been a little bit ambiguous about whether or not they mean all codes or not, but we know that there was something in the in one of the acts that they put forward. Anything to add there, Christy? I know you're the expert on this.
Well, I would just add that as you watch this, again, the end of waivers doesn't mean the end of telehealth. And that's often, that's a myth out there. So just know what the waivers are specifically, and how they impact you and your organization, and what you may need to adjust. And we're going to talk about that.
Exactly. So let's talk about advocacy. We know that the Federation of American Hospitals represents managed hospitals, et cetera, a bunch of organizations across the country. They said to HHS, please renew the COVID-19 PHE through the end of 2023. So again, a call because of this ambiguity around whether or not folks are actually going through these codes are actually going through 2023 or not. And then, of course, we saw the advancing of the HR 4040, which has been huge for critical access and rural organizations, because this would extend those critical access waivers through 2024. And there would not be any originating site restrictions and things like that. So we know that this is already passed in the House with overwhelming support, and now it is in the Senate. Like typical politics, some people are putting their little, nitpicky things in there, but we are trying to work with all of our senators to get support for this, given that it is a bipartisan issue. Telehealth always comes up as a bipartisan issue every time a bill comes forward. So if you're in your state, please let your senators know about HR Bill 4040, that they need to approve that, they need to vote for that in advancing telehealth and beyond. And then here are some specific codes around what rural health clinics qualify for furnishing services to a distance site. And I'll let Christy speak to this slide because I know it's very specific around codes and the actual dollar amounts. So Christy?
Sure. So for the remainder of the PHE, rural health clinics, if you're in that position, you know that you now get, you're able to function as an originating site and a distance site. And that previously was not the case, and your all-inclusive rate has been adjusted. And there are some codes there for that. You have the addition also of being able to do, there's inpatient observation services that you can continue to do. There was lifting of pre-COVID frequency limitations, and that's not specific to rural health. That's actually anyone who sees patients in the hospital. You are now able to see them, whether it's a hospitalist or a specialist. From a perspective of payment in CMS, you can see them admission, subsequent, and discharges. That may not jive with your bylaws, so you need to make sure that you're following, all pertaining things. So, but what digital and virtual communications expansion? So audio right now will continue through the end of the pandemic in the 151 days or the end of the calendar year, however that shakes out. Past that, we do still have audio only options, and we want to talk about that as we go through this section.
Okay, great. So let's build on the foundation of what we know already. We know that you can continue to act as an originating site for telehealth services. You can expand your specialty telehealth service offerings if you're originating site. Utilize your rural health residents, other clinicians to help capture the higher acuity of care, and then collect your originating site fee. A lot of times folks aren't even aware of this, and they may not even be billing this. So definitely try to collect for that. It's important that we utilize the codes that HHS and CMS have provided to us so that we can demonstrate that this is important. So if you're not currently billing for codes, then you need to do that. So we've seen CMS, for example, say, well, you haven't utilized this code, so why should we expand on that? Part of the reason sometimes we don't use those codes is they're not as helpful as we would like for them to be, but at least if we're able to do it, let's utilize them. Christy, what are your thoughts?
Yeah, and this is, I think this is huge. And in the rural areas, doing this even now in bringing patients in to see specialists into your clinic, so it's not necessarily from the home. This is a great way, especially for people who don't have that technology access, to still remain in their community, yet connect with a specialist that may be further away that you have, a working relationship with. So it's a really great way to still provide access within your community.
Yeah, great point. And then on the mental health side, I'll let you speak to this slide.
Okay, so post-PHE, RHCs can receive payment for mental health visits furnished through telehealth technology. And basically, that has been a permanent that has gone into place, legislation that has gone into place for all sites. Audio only will continue to be acceptable when patient does not have or not willing to use video, and that's for behavioral health. And there's a modifier that you would use, FQ for CMS. 93 has been out there for other payers. You're going to want to check because these are kind of flipping back and forth as to what they want you to use. So you want to follow that, but there will be a modifier to indicate audio only service. And there's still that whole must have an in-person visit once every 12 months, 6 months. Who knows what it is right now. That will go into effect at the end of the waivers and when they expire. But again, there's a lot of advocacy out there for that. And there's also there is an exception where you can document a reason why it wouldn't be, the in-person visit would not be feasible. So you want to look into what those scenarios are.
And we've also seen that happen with mental health, where they've said this arbitrary 6 months, and there's been a lot of advocacy around that. I think HR 2020 or 4040 gets rid of that as well. I should note on this slide, it says post-PHE 1122. This is based on some information that we had done previously. So that date is just, think of that as post-PHE. So whenever that is, we just had the extension that goes through January 2023. And then we are not sure what will happen, if that will take us through March or April the next time. But certainly with the 151, I just want to note that because our slide has an error on there, and I don't want someone to take a picture of that and then later on talk to folks about that one as well, and utilize that wrong information. On the digital communication sides, rural health clinics, for example, can bill the virtual check-ins. The G71 code is a great one to do. The audio only is acceptable. These have to be patient initiated. We've talked about this before, but you can kind of do ticklers to the patients to remind them to contact you, which is appropriate and allowable. It can lead to an urgent care rural health appointment, which was typically it cannot lead to a rural health appointment within the 24-hour period. And we talked about this one face-to-face billable in the last previous year. So it can't just be a virtual check-in. So this is kind of just a virtual visit with that patient. This virtual check-in is those types of visits where the patient has asked about a particular situation. So not around their visit that they had in the last 7 days, but just something that's come up and they're asking you about that through any type of portal or messaging system that you have set up. And you're answering that question at their request. And that historically had not been payable until the virtual check-in code was initiated. And the virtual check-in was in place prior to the PHE and prior to COVID.
Yep.
Also, we should note you do still have to have the standard consent files on consent on file in order to have digital communications with those patients.
I just want to note too, for outside of rural health, that there's the virtual check-in code, G2012. There's been an additional code added, and that is now permanent as well. That adds for longer time periods. So if you're on the phone, let's say the phone is your medium for communicating, and I believe it's 11 to 20 minutes. For that code. So they're recognizing that there are phone calls that last longer than the the kind of 5-minute arbitrary time that they put there. So this is a valuable code across the board. Will still be, will be in place. It was in place prior, will be in place after. And I would recommend that you put processes in place to capture this.
Yep, absolutely. It doesn't seem like a lot of money, but if you could capture all those dollars for each time that you do those types of communications, it can add up. And why not take advantage of it?
Mm-hmm.
On the inpatient services, we know that there's telestroke, critical care consultations, and specialty inpatient consults, as well as e-consults. We know that we'll talk a little bit more about that. Did you want to add to this as well?
Just that these are things, remember, these are things that will continue post end of waivers, whenever that may happen. So don't throw, the baby out with the bathwater. You want to make sure that these things that you have in place, you can still continue to bill for these things. And remember, telestroke is not regionally, geographically restricted anymore either. So telestroke can be leveraged across all sites. Specialty inpatient consults, that is geographically restricted if restrictions go back into place. But again, that would be great for rural health hospitals that need access to that specialist.
Absolutely. Yep. Same with those e-consults as well.
E-consults. The e-consults is a great, it's a couple of things. It's great access to patients in the community. It's provider to provider, and it's really gaining traction across the nation because it's so effective. In resolving a lot of issues that do not need to be escalated to an in-person or even a virtual consultation with that specialist. Yep,
exactly. All of these provider to provider consults that in a lot of cases they were not paid for.
Mm-hmm.
And now they are. So we talk a lot with our clients around leveraging the proxy credentialing. Anytime you have the streamlined process for proxy credentialing for an originating site, this is a good process to include. To have for all the reasons that we just talked about, the provider to provider consults, the provider to specialty consults, or patient to specialty consults. If you're inside the hospital and you're allowing proxy credentialing from a main hospital, for example, versus a critical access hospital, as long as there's a written agreement between the organizations and you're reporting data between them, then you can take the proxy credentialing and privileging and again, put that into your medical bylaws between the organizations so that you can cut down on the time that it takes for you to be able to utilize a specialist from an organization that you might be partnering with. So if you are a critical access hospital and you are getting services by a main tertiary care facility in another main city in an urban area, you want to do proxy credentialing so that you don't have to take the time to credential the person who's already been credentialed and privileged at that main hospital. So talking to your medical affairs department to get your bylaws adjusted so you can use that proxy credentialing will allow you to be able to work together much easier.
And we could do a whole webinar just on this, but I do want to mention that it's also known as delegated credentialing. So you might hear that term with this whole telehealth, virtual care, digital care. We have a lot of terms that are used interchangeably. So if you've heard delegated credentialing, that's the same concept.
Yep, good point. Okay, so let's talk about what's going to happen in the unknown. So if the waivers are extended or made permanent, consider that strategy of what's going to happen. So match your strategy for your mental health services, your wellness services, your chronic health, as you can see, maternal health. These are areas that are major areas of need across the country, across facilities. So when we have our waivers extended or we get them made permanent, already put your processes in place that said, we're already doing this. We can continue to do this and continue to care for patients. Even in states, we've seen some states extend and make these services permanent via telehealth just because of the circumstances that are happening in the state. Mental health, for example, already being paid in a lot of different states at those levels because they know the mental health provider scenario is a lot of shortage in that area, and also mental health providers, a lot of need in that area as well. And also maternal health. We see a lot of states that have a high maternal mortality or a high infant mortality and a maternal fetal mortality, and that's allowing them to monitor those patients, for example, and that's already happening because of the scenarios in their individual communities around maternal health and around mental health, for example. We're already seeing states put things in place. Audio only, look at the appropriate expansion of audio only beyond the virtual check-ins that we've been talking about. Definitely for any of these services, we talk a lot about helping folks understand how to create the clinical guidelines and workflows around telehealth. This is really important because we find in a lot of our clients that not only do they not have clinical guidelines or any types of guidelines around telehealth, that their workflows, if they just were tweaked a little bit, they would be able to take advantage of some of the telehealth services that are out there. And then utilizing audio only for educating patients, families, and staff, and help them understand what audio only is and how we can better care for them through an audio only. Rural sites, rural health clinics, ability to use them as continue as a distance site, regardless of whether or not this is extended or not. That identifies some high value services as we've identified there. The workflows that we've talked about in the past, this is important, particularly for capacity management, where we see in the rural areas that I've spoke about many, many times are older, sicker, and more chronic disease, and also have a higher level of clinician shortage in those areas, none more now than post COVID. And then, of course, your cancellation and no-shows. We definitely have already seen publications that have shown and research that's shown that telehealth reduces the no-show rate. So take advantage of that. And then again, educate your patients on how to connect to their telehealth resources. What would you add to that, Christy?
It's so important to consider your strategy, and something that's really becoming popular amongst especially integrated healthcare organizations is starting to work directly with employers around services that they can offer via telehealth, because you know what, you're not constrained then necessarily to payment regulations with an insurer. So just consider that, and consider as you move into the future that taking what we've done, which is really during the pandemic, we were exposed to telehealth. We all had to do it. So we've all gotten the taste of it. But really, we took what we were doing in person and just moved it to a new medium. What we want to do now is really look at transforming care. So that would be the next step, the next horizon that I see.
Yep, really good point. Yep, and utilizing it as part of the continuum of care.
Yes.
Okay, so we have a few other slides to go through and only just a couple minutes left. So I'm going to go quickly. Take a look at your telehealth infrastructure, including your governance. This is probably something that people have already taken a look at. But if you haven't, put a governance structure together. It's going to be an onslaught of services that people will want, and you need some kind of governance to help you manage the volume that'll be out there. Consider your partners that you want to utilize and the technology. Is it the right fit for you? A lot of people bought things really quickly with FCC money, and now they're regretting those decisions. So come back and look at, is this a right decision for you from a technology perspective? Does this help you bring your telehealth program to, as Christy mentioned, as part of the continuum of care, part of the elevating clinical practice? And some of the resources and tools that we recommend, you have a resource center in your area. This is the National Consortium of TRCs. No matter where you are across the country, there is a TRC. These are free resources. Of course, Blue Cirrus also provides resources as well. We have a lot of free things on our website. And the TRCs do as well, but take a look at where you live and which TRC might be the best for you. There's a lot of summits that they do, particularly now in the fall, and then in the spring, a lot of them will have some kind of education sessions that will be offered either via virtual or in person. We also have a National Digital Inclusion Alliance. So a lot of service providers here that will provide practitioner support, some advocacy, and increased awareness. There are also links to some public resources, and you can join as a member to this alliance at any time. So there's a lot of information here that can allow you to get more information around telehealth, and that's always a good thing. From a senior perspective, a lot of folks are interested in the geriatric care that is out there and education for seniors. Telehealthforseniors.org is a great website. Also, we're seeing the senior action type of organization. We're seeing the it's Center for Aging. I was losing it in my mind. Center for Aging is also doing some heavy work in this space as well to try to educate seniors. And keep in mind, we're not just having them be educated on here's how you connect to your hospital. They're utilizing the education to say, here's how you connect to Pinterest. Here's how you connect to Facebook. Here's how you do a FaceTime video with your grandchildren or with your children. So it meets them where they are and the things that they want to do with technology, and then allows them to parlay that into how do you access your healthcare provider as well. Here's a great resource for people that are looking for devices, for example. This allows you to, folks that are, this is a private public collaboration with HUD. So if you are qualified for HUD and any assisted housing, this is usually providing you some kind of digital technology, allows you to have some community-based platform. And again, it addresses the digital divide that we saw kind of explode during COVID when so many people had to use a digital solution. And then TrueConnect is another program. It's a federal program where if you actually qualify for SNAP or WIC or any other public housing assistance, you qualify for this. It can give you a free device and wireless internet. And you can see for households earning up to 200% of the FPL or eligible for any of these programs. And then there's wireless hotspots as well for $20 a month. So it's well worth handing those off to your case managers so that they can be aware of what programs are out there. Also, Starlink. We see a lot of folks. I know there's a whole bunch of stuff in the news about Elon Musk, and I'm not going to get into that, but this is an ideal scenario for folks that are in rural areas or in remote communities where you may be serving, that can allow you to access broadband services via satellites. I will say that this is also happening with AT&T, either with their DirecTV or whatever their satellite connection is, that they are, I've heard recently that it's not DirecTV, but it's something else now. So that's why I'm hedging on the words. But this allows people to access broadband through a satellite instead of waiting for that, final mile of line to be connected to their home. And I will say that some state legislators are paying for this service. So if you're interested in providing satellite services, satellite broadband access to your patients, you may look in your state to see if your state funding allows you to pay for this service specifically. So it's been specifically identified in some state budgets to pay for this more satellite driven broadband access.
Right.
Thanks for the extra word. We are just about 2 minutes over, but I wanted, Christy, for you to get a chance to add to that. I'll stop on my last slide, or I guess I'll keep my contact information up as well, but anything to add on those last few slides that I put together there, and anything that you would add?
I think that what you saw just underscores the explosion that happened and the awareness that came out of that, right? A lot of programs put in place to start to address the digital divide and some of the digital literacy that we need to see improve across the nation. So this is a really exciting time to be in healthcare. I know it's been a rocky road the past couple of years, but for those of you in healthcare, number one, thank you for serving and on the front lines. And those of you in the back, we're all there to support them, and thank you for doing that. And it's going to be, I think we're going to see a lot come out of this.
I agree. Usually we have that thank you to our healthcare heroes on our webinars. So thank you for mentioning that. Thank you for everybody who's on the line. We also, as I said, have all of our previous webinars on our Knowledge Tsunami. Please feel free to look through those topics. Christy and I have done several of these that are coding and compliance specific. She's the expert in that space. And also we've done some panels that are just, discussing future topics. If you have a topic that you're interested in and that you'd like for us to cover, please feel free to send me that question or send it to our info@bluecirrus.com, and we will cover that topic. And that'll be our next webinar topic. Is I think our next one, we are doing a panel discussion on remote patient monitoring, which has been coming up quite a bit. Lots of people interested in remote patient monitoring, remote physiological monitoring, I should say, and then also the RTM. So we'll be doing a panel discussion next month on that, which will include myself as a moderator. It will also include Dr. Stephen Morgan from Carillion Clinic, and it will also include Sherry Hess, who is this Chief Nursing Informatics Officer for HCA. So we will be honored to have the two of them, an MD and an RN, to talk about RPM and those successful programs. Excuse me. And our own Amanda Bornicore as well, who also will be on that webinar. And she will be talking, all three of them will be talking about remote physiological monitoring. Thank you for being here today. We're just a couple minutes off, but hopefully that helped fill your lunchtime period and you were able to get some good information for your work and your everyday life. Please feel free to email me if you have any further questions.